Hello, I'm Dr. Ward Dean, Medical Director for Vitamin Research Products. The first International Anti-Aging Conference, which was sponsored jointly by Vitamin Research and International Anti-Aging Systems, was held on June 17th and 18th, 2000 in Monte Carlo, Monaco. The conference attracted scientists, clinicians, and anti-aging enthusiasts from around the world. These tapes offer an opportunity to listen to the wealth of information that was presented. For those who were unable to attend the conference, it offers a hint of the experience that they missed. Please join me as I listen to one of the speakers at this breakthrough conference. I cordially invite you to join us at the next conference in Monaco next year, which promises to offer a similar roster of international specialists in anti-aging medicine.
Our last speaker today graduated in biochemistry and immunology at the University of Bucharest. His expertise has now established him as an expert in the field of dermatology. From his superb faculties near Munich, he has established a number of testing parameters which could have major implications for aging and supplemental biomarkers. To elaborate further, please welcome Professor John Ionescu.
We are running in Germany, in Neukirchen, since 15 years, a special clinic for skin and degenerative disorders, and are concerned with the most difficult cases of atopic eczema, psoriasis, autoimmune disease, and environmental disease. The good news is that German insurances are reimbursing the fees for these treatments, and the second good news is we are dealing here with integrative treatments. And as we all know, that the aging process is very, very speeded by a presence of chronic disease. I'm trying to show today the implications of some quite new and applicable tests, which are showing us which is the biological terrain in patients with different disorders, and also in geriatric patients. One of the main problems that clinicians face in the daily experience is that the very moment that we are applying an antioxidant or an oxidative treatment, we never know about the impact of this therapy in the body of our patient. We suppose that it will help, but as we'll see today, there are a lot of clinical situations where we get, in fact, the opposite effect we'd like to get. And this is because our patients, exactly as geriatric patients or aging people, everybody has his own biochemical individuality. And that's why the drug number one, which suits for the first patients, it doesn't necessarily suit for the second or the third patients, as we'll see today. And what I'm trying to say is that we badly need monitoring tools and diagnostic tools to show which are the real effects of our therapies in chronic disease or in premature aging. You may ask yourself if between this terrible clinical condition, it's a very, very acute toxic dermatitis, and several or certain markers of the internal milieu, as for instance the redox systems in these patients, or the levels of free radicals, if there is a direct connection. I can assure you, and we'll see in the next minutes, that there is a direct connection and interrelation between disturbed redox systems in such people and also between significantly increased levels of free radical in all these pathological situations. I don't want to make the whole story of the redox systems, of the redox processes. Anyhow, if we are speaking about redox processes, we understand, first of all, electron transfer reactions. There is no life, as Professor Nagy said before, there is no life without electron transfer reactions. And these electron transfer reactions are taking place in biological systems between redox pairs. Redox pairs, we have here the reduction of the parabenzoquinone to hydroquinone, or the oxidation of the ascorbic acid to dehydroascorbic acid. And between pairs like this ascorbate, dehydroascorbate, or parabenzoquinone, hydroquinone, or in our case, in our body, ubiquinone, or CoQ10, between this redox pair, we have electron transfers enabling the life, enabling the energy generating reaction, enabling the ATP production and so on. Well, some important redox pairs for our body are depicted in these pictures, and it's important to know that the electrons are always running from the lowered redox potentials of such pairs as cysteine, cysteine, lactate, pyruvate, cytochrome B in reduced and oxidized form, up to the more oxidized redox pairs, as we have here the hemoglobin, methemoglobin, the cytochrome A, E, and up to the oxygen at the end of this respiratory chain. So to evaluate this redox pair, we have two main possibilities, I would say. We have the arithmetically calculation using the Nernst equation, but this is not possible in such a complex mixture what you have in the body, in a blood fluid or in the plasma or in the tissue. It's not possible to use the Nernst equation. And much more interesting and much more feasible is therefore the using of the potentiometry for such situations. We know since 1960s and 1972 afterwards, Professor Shapiro introduced the terms of redox balance, the terms of oxidosis, the terms of redosis for biological systems. What does it mean, oxidosis and redosis, as compared with acidosis and alkalosis that everybody knows about this? The oxidosis, we have an oxidosis in our biological systems when the concentration of the oxygen is high. We speak about a respiratory oxidosis, or vice versa, when the concentration of non-volatile oxidant stuff, and here are enclosed, we have a lot of toxins coming from outside, are getting increased in the system. Or when the oxidant part of the redox pair are in excess as compared with the reduced parts of these pairs. And by contrast, we have a redosis systems with low EH potential, redox potential, when the partial oxygen pressure is low in the system, or when we have an increased production of reducing equivalents. Indeed, we can find this situation in a lot of clinical conditions, oxidosis or redosis. Before I'm starting to show you our measurements, how we can measure these things very easily, I'd like to remember that the oxidant amounts, the antioxidant amounts in the body are decreasing as a function of age. That's a quite important fact. And already in the 50s and in the 70s, we had a lot of papers describing the reduced amounts of antioxidant stuff as, for instance, selenium, blood vitamin C, cerebral cortex vitamin C, pectoral muscle vitamin C, vitamin C in spleen and adrenal gland, vitamin C in serum, liver, thymus, and lung, and enzymes as superoxide dismutase, catalase, or glutathione peroxidase as a function of age. CoQ10 was also described today. Dr. Ward and the others showed these findings by decreased coenzyme Q10 levels as a function of age. Well, there are also some preliminary study in the 80s describing significant oxidosis changes in geriatric population when compared with a healthy population. So the more we age and the higher the frequency of diseases associated with the aging process, the higher the oxidative state in the body. You may see here the EH expressed in millivolts is increasing from 260 to 300, 310 as the middle levels in these geriatric populations. Well, how can we measure easily such changes? We developed in cooperation with the University of Erlangen electrochemistry department a prototype spatial temperated redox cell where you are analyzing the blood samples or serum samples or fresh plasma samples taken in vacuum in an argon or in a nitrogen atmosphere to avoid a further oxidation of the sample. And within a few minutes, 5 to 10 minutes, we get the so-called redox time curves, redox potential time curves, showing us which is a steady state in this particular patient, control, healthy people, or in different foods, juices, supplements, etc. We can also monitor quite nicely these curves on our PC program, and we can get very clear-cut curves. For instance, we have here, if we are investigating the venous blood, we have here a control person with a minus 103 millivolts redox potential in whole blood. By contrast, a patient with atopic eczema chronic atopic eczema is showing a redosis state, minus 133. The normal range we found in hundreds and hundreds of patients was between 100, 118, 120, minus 180, the normal range in whole blood. In serum, we can have different conditions. Here is the normal range in a control person, minus 100 millivolts, normal range from 80 to minus 100. By contrast, a psoriasis patient with acute psoriasis was found in a severe oxidosis by minus 70 millivolts. The same story, if we make the statistic of such observations, we found easily that patients with atopic eczema and patients with psoriasis, they've been in a significant oxidosis state in serum as compared with healthy people, as you may see here. We have a very significant difference, P smaller than 0.001, when compared these two groups. However, we have also people in the normal range, a few of them, or in a redosis. There have been people taking antioxidants, changing their normal pattern, their normal untreated pattern. Therefore, we always advise people reproducing our experiments to investigate only non-treated patients, only fasted patients in the morning and without any therapy before. Now, the question we have as therapists or as researchers is how can we modify, quite simple and quite efficient, the changes in this redox potential and afterwards in the free radicals concentration to get again a normal state, to get rid of the symptoms, to get a normal state. We have here in a control person a normal redox potential minus 190 millivolts. Now, if we want to change this level towards redosis, we are just giving in the sample, we can give it in vitro, a few milligrams of reduced glutathione, and you get immediately a significant movement towards redosis. The glutathione will move the curve to minus 161 millivolts in vitro. If you calculate now how much glutathione I need to get the same results for 5-liter bloods in vivo, then it's 1,000 times more. Here we made it in 5 milliliter blood. And if we give 1.2 grams glutathione in vivo, intravenously, we can measure 15 minutes later almost exactly the same change in the redox potential in vivo. Okay, we take a new blood sample 15 minutes later, and we have immediately almost the same. Before it was minus 161, we have minus 163 as an excellent correlation with the test we did before in vitro to see what is doing our antioxidant. Quite interesting is now, ladies and gentlemen, that this level, what we get here, it will not remain like this too long. And how long it will keep this level is depending now, as I said at the beginning, is depending on the biochemical individuality of this patient or premature aging people. What do I mean? In case we have a strong oxidosis situation in the body with toxins, heavy metals, for instance, or chlororganic compounds and so on, this will immediately oxidize the glutathione so that the curve will come back within 1 hour or 2 hours. We are burning the whole antioxidant we just injected in these people. Very important, the individual biochemical profile of every patient. Now, this situation is quite interesting and quite important because we have a lot of hypoxic conditions, or we have a lot of conditions which increase xenobiotics in the body, toxins in the body, which are blocking the respiratory chains in the cells, blocking the energy transfer, blocking the oxidative processes, blocking the phosphorylation, blocking the ATP formation, and enabling the accumulation of reducing equivalents. This is a very important phenomenon we get in a tremendous amount of clinical situation, and probably also in normal people, rapid aging people. This accumulation of reductive equivalents here is also happening in cancer cells. Cancer cells with a decreased oxidative process, they have large amounts of NADH, NADPH, glutathione, and so on, and are very resistant because of increased reducing equivalents against oxidants, against all kinds of therapies. So this excess of reducing equivalents in such cells protects them against cancer therapies, against effective cancer treatments. In this situation, ladies and gentlemen, it's totally wrong to offer these people antioxidants. It's totally wrong. You need an oxidative treatment to change the system, to change the blocked system with a very strong redosis, intracellular redosis. Now, what kind of possibility we have to change such a situation? Which are the simplest oxidative therapies we have for diseased, also for healthy people, but not feeling good or down energetically and so on. To burn out this excess of reducing equivalence, we have generally 3 or 4 main therapies: exercise, fasting, hyperthermia, and, as discussed today, sometimes the thyroxine hormone, the thyroid hormones, okay? 4 very easy and very simple way to increase oxidations in biological systems. If we send our people here, a healthy control person, with a basal level minus 120, if we let him 15 minutes jogging, we get immediately a response, an increase in the oxidative response of the blood after this 15-minute jogging. So if you need an oxidative treatment, just start jogging first. The second possibility, as I said, is hyperthermia. We can get hyperthermia in the sauna shortly, okay, but it's also very interesting oxidative stress for the body. And you may see here, before the sauna and after 10 or 15 minutes sauna, a significant increase toward oxidosis, a significant oxidative effect of the sauna therapy. We can also get the same effect in systemic hyperthermia, as for instance in cancer patients. Cancer patients in the United States, in Germany, here is in our clinic in Germany, we are cooperating since 2 years, but also in the United States, in Tijuana, we have run experiments showing, quite interestingly, that hyperthermia is significantly increasing the blood redox potentials towards oxidosis and, like this, attacking and destroying cancer cells. Hyperthermia. Here you can see the curves before hyperthermia, the basal level, basal redox potential before the therapy at 9 o'clock in the morning, and here you may see 3 hours later at 12 o'clock, minus 15, minus 18, also tremendous increase of the redox potentials through hyperthermia. Here it's the same monitoring in another patient, minus 164 before the therapy, here at 9 o'clock in the morning, minus 139, 20 millivolts, 25 millivolts difference at the plateau at 42.5 degrees Celsius, core temperature in the hyperthermia patient, and coming back to, and still keeping at minus 147 after hyperthermia. The partial oxygen pressure is also significantly increasing from 68.9 millimeter mercury to 116.2 milliliter mercury through this hyperthermia treatment. Very, very interesting. And we also get a slight acidosis, a lactic acidosis effect from 7.4, the pH, coming down, dropping to 7.28 and still staying at 7.3 after the hyperthermia treatment. 6 hours takes this therapy. Another possibility, and is very well known and spread in the whole world, are therapies with oxidative stuff infusions as hydrogen peroxide, 0.03%, or dioxychlor, or things like this. In vitro, you can easily see immediately the oxidosis effect. If you add a little bit of hydrogen peroxide here and a little bit more, once again, you get a significant change of the redox potential toward oxidosis. And similarly, with dioxychlor, also a very strong oxidant, before and after dioxychlor, we get a strong, we get an oxidative impact, we get an oxidative stress. How is reacting the body to this? If we get a stressing substance from outside, the body will mobilize, of course, in an adaptive response, his antioxidative systems. Enzymatic and non-enzymatic antioxidative systems will be mobilized against such aggressive oxidants. And we followed infusions. The infusions in these people, they are very common in the United States and also in Europe. The infusion of hydrogen peroxide or dioxychlor through intravenously over 2 hours or 3 hours, 2.5 hours. And we see here that immediately after the infusion, both for hydrogen peroxide or dioxychlor, we get a redosis response of the body, and 30 minutes later, even a stronger redosis response. The body is mobilizing his antioxidative systems to compensate this oxidative stress. Well, another integrative, known as integrative therapy, is the photooxidation. You probably heard about this. It's practiced in the United States, in Germany, in England, in New Zealand, and so on. We are speaking here of the UVC, ultraviolet C radiation of the blood to induce positive changes in patients with chronic fatigue syndrome, with skin disorders, or with multiple chemical sensitivities, or with chronic infections too. Now, what's happening here? Before the irradiation, we have a basal level by -97. After the irradiation, a very significant redosis effect. It's again a response of these biologic systems against of the production of superoxide and singlet oxygen through the irradiation, through the ultraviolet irradiation. Always we have to think about the response of the body. Now, if we add some very toxic xenobiotics as methylmercury or pentachlorophenol, okay, polychlorinated biphenyls or pentachlorophenol, we get a significant oxidative effect for these two toxins when compared with the basal line in this control person. And as we know that toxins are generally inducing oxidative effects, yeah, are blocking the electrons, are taking the electrons, we can avoid such an effect treating the patients previously or treating afterwards if we know that there is a burden with methylmercury or a pentachlorophenol in the body with appropriate chelating stuff, chelating in brackets. Chelating stuff is for instance here N-acetylcysteine. If we get the oxidative effect of the methylmercury here as compared with the basal level in blue, and if before this experiment we add a little bit of N-acetylcysteine, which is alone inducing a strong reducing effect, we get a beautiful blockage of the negative effects of the methylmercury, and we get an all-over redosis, slight redosis effect because of the strong reduction activity of the N-acetylcysteine. N-acetylcysteine is blocking mercury, as glutathione too. Okay, PCP, pentachlorophenol, a very strong chlororganic compound. It's also inducing chronic oxidosis with deleterious side effects for the respiratory chain and so on. But if we add, before of the PCP, some aloe extract, including the well-known glucuronic acid used in our liver for the conjugation with the pentachlorophenol, we get the elimination, the prevention of this deleterious effect of the pentachlorophenol. As you may see here, the overall effect is a slight redosis. So we are blocking the negative effect of this poison. So you can very well follow all kinds of experiments and the effects of your therapies. If you give something, you see how it happens, what's happening in the body, positive, negative, or if we get the patients in the normal range by serial examination this time. What about foods? What about juices? If we give the patient, here is an atopic eczema patient, 1 liter, 1,000 milliliters of freshly pressed carrot juice. Quite interestingly, we get a significant oxidosis effect from -128, a slight redosis. We had before a similar case. It's in a redosis state, coming back to the normal range by means of this carrot juice, a slight oxidosis effect. Also very, very advised for cancer patients, the carrot juice. Look, the Gerson therapists and other researchers. Here, redox potential before and after ingestion of 700 milliliter fresh grapefruit juice. Grapefruit juice is also a fantastic anti-cancer and redox-rich compound. We have a lot of polyphenols here, and here is the fasted patients before the ingestion, and here we have a significantly oxidosis effect only from 700 milliliters of grapefruit juice. Okay? Think about this when you treat chronic fatigue syndrome patients or you treat cancer patients. Such juices can improve dramatically the clinical condition of your people. Here are some other effects from blueberry juice. We have a redosis effect this time, and the Selagon juice mixture is a vegetable concentrate in Germany, very effective, and also here we get the opposite effect. We get a significant redosis from these juices. So according to the situation your patient is showing oxidosis or redosis, you can beautifully correct the situation with the appropriate choice of freshly squeezed juice, vegetables, and so on. Now, the green tea has a very interesting oxidative effect, was recognized in the meantime as a very potent anti-cancer agent for all kinds of skin cancers and epithelial cancer and intestinal cancers. Vitamin C, ladies and gentlemen, everybody knows strong antioxidant, vitamin C, Linus Pauling, up to 20 grams a day, up to 30 grams a day. You know the story about the vitamin C. Yeah? Is it true? Is it a good supplement for everybody? Is the big question. Or how much needs everybody is the second big question. Okay? Here, for instance, we have a multiple chemical sensitive patient, MCS patient, with a significant oxidosis state in serum, in plasma or serum, okay? Significant oxidosis state. Normal range would be 85 to minus 85, minus 100. Now, if we give him intravenously 8.5 gram vitamin C, in this case, we also gave 20 grams, we also gave 30 grams, but in this case, we gave 8.5 grams vitamin C. 15 minutes of infusion, the infusion takes 1 hour, 15 minutes after infusion, we get a significantly redosis effect. You know, vitamin C is a very strong reductant stuff, by minus 127. But now, 90 minutes later, if we take another blood sample from the patient staying, just laying on the bed, not exercise, not eating, doing nothing. 90 minutes later, we get already a comeback towards the initial range. 5 hours later, we are very near to the initial range. And 6 hours later, ladies and gentlemen, we have everything is burned from this antioxidative activity in these people. What does it mean? You can give your people grams and tens of grams of vitamin C. It will burn it extremely fast in case his internal biochemical chemistry is directed toward strong oxidations. In case of this patient, for instance, has large levels of transitional metals in the circulation, in plasma, in serum. These metals are enabling a very, very fast oxidation, the so-called auto-oxidation of vitamin C. It takes place in presence of oxygen very slowly, but in the presence of metals as iron, copper, mercury, cadmium or lead or lead, it's extremely speeded, this oxidation. So as long as your patient is not released, is not free of this toxic burden, and not only the metals are doing this, toxic burden, you will burn tremendous amounts of antioxidants without getting any durable effect. Next day, the patient will have the same redox potential. It doesn't improve at all. And if you stop this supplementation, 1 or 2 days later, you have an absolutely initial state, no improvement of the clinical condition. The bad point is here, in such people, that when you give large amounts of ascorbate or of thiol compounds, as glutathione, cysteine, N-acetylcysteine, or whatsoever, we get a very strong oxidation of these compounds with large production of free radicals. Large production of free radicals, first of all, of superoxide. And this superoxide, here is the redox cycle in the catabolic pathway of ascorbic acid, where we see how the steps where superoxide is produced from the ascorbic acid monoanion to the ascorbic acid radical, with the first production of the superoxide radical in the presence of iron and the oxygen, and here a second production of the superoxide radical from the monoanion radical to the dehydroascorbic acid. In the oxidized form, the dehydroascorbic acid can happen 2 ways from this point. Towards back to the ascorbic acid, to be reduced to ascorbic acid if enough glutathione is available in the system. But if we don't have enough glutathione, as in many cases of chemical sensitive people, for instance, or autoimmune disorder and so on, if we don't have enough glutathione, we get the dehydroascorbic acid will be definitely and irreversible splitted to decatogulonic acid, threonic, and oxalic acid. So we have a loss of ascorbate, elimination through the urine, through the urine, and no recovery of the ascorbic acid. And this is exactly the situation where we have in such people who cannot maintain their ascorbate levels in spite of repeated injection or capsules or large amounts of oral ascorbic acid. And here is a similar phenomena. You may see here that ascorbate oxidation, as shown at 250 nanometers in a spectrophotometric, very simple experiment, is running very fast if we have a mixture from serum, ascorbate, and mercury chloride. Mercury is very speedily oxidizing the ascorbic acid. Here we can stop this process if we add a little bit of glutathione. That's already started process. But if we offer at the beginning a little bit of glutathione together with the ascorbate, we have no oxidation of the ascorbate. Glutathione is protecting the ascorbate from the deleterious oxidizing effect of the mercury. It's a very important point. So think about a combination of antioxidants if you want to protect such things, and not only one, okay? Because most of your patients, being in a chronic, in a very difficult oxidative state, they don't have not only low levels of ascorbate, but they have only low glutathione levels, low NADPH levels, so you need a complex or with protective effects. Sometimes you had also to add polyphenols, so what we have in a lot of juices and natural compounds. Now, as I said, we get a lot of free radicals produced in the body, and doctors are reporting again and again and again. I'm very confused. I gave ascorbate. These people was to dentist work, to drilling work, and he got rid of his amalgams. And afterwards, I get ascorbate to improve his clinical condition. And look, it was even worse from day to day, from day to day. Of course, if you get an increased amount of amalgam, of mercury in the body by drilling work, this will destroy immediately the ascorbate you are just getting intravenously with production of superoxide radical. And this superoxide radical is the first radical in the well-known cascade of hydrogen, of free radicals, hydrogen peroxide, hydroxy radicals, was beautifully discussed today by Professor Nagy, singlet oxygen, and the oxidation of we'll discuss a little bit later, the oxidation of the fats with production of peroxides. So these are the most important free radicals, and these free radicals are involved in all inflammatory processes, in atherosclerosis processes, in microcirculation injury by inactivation of the nitric oxide through superoxide radical, and also in cell injury, membranal damage, already discussed before, and DNA damage leading to cancer mutations, to cancer, cell mutation and cancers. But they also help us. They help us when we need these good fellows in fight against bacteria and fungi and viruses. We need these free radicals in the respiratory burst, helping us to destroy the membranes of these invaders, of the bacteria, or killing fungus, and so on and so on. So there are two sides of these aspects in the body. The problem is that when the oxidative and antioxidative processes, when the free radicals and the quenching compounds for free radicals are no longer in a balance in the body, and the free radicals are in excess because of prolonged infection processes, for instance, or prolonged toxic exposure against chlororganic compounds, heavy metals, and so on, then we have this chronic damage of our membranes, of our proteins, of our lipids, of our DNA material, and we have, of course, the speeded aging process and the disease process that we all know from our patients. And to measure these things, ladies and gentlemen, the free radical theory of aging is one of the 5 main theories, and we are trying, in the frame of this theory, to show and to objectify how much free radicals do we have in these people, in this patient, how much we have in the other one, how can I block the production of these free radicals to get him symptom-free and to stop this history disease. So I don't have the time to get into details. Anyhow, I'm just showing here the very important mechanism of oxygen radical production, free radical production by phagocytin, activated macrophages, production of superoxide, hydrogen peroxide, hypochlorous acid, and so on. Very, very important stuff in the fight against bacterial and viruses and fungus. Here, the already mentioned today, the Fenton reactions and the Haber-Weiss reaction, the non-enzymic free radical production in the presence of iron and copper with very significant amounts of hydroxyl radical, the deleterious, the most aggressive free radical, as before discussed by Professor Nagy. And this free radical, this hydroxyl radical, is extremely important by attacking the membrane layers, and especially the polyunsaturated fatty acids in the membrane layers. And if the density of these compounds, as you before said, is very high, we get a cascade reaction. From one free radical to the next free radical to the next free radical, we are destroying the whole structure, if the structure is dense. Okay? Here you see such a cascade phenomenon with production of different free radicals, peroxides, lipid peroxides, yeah, peroxyl radical, the lipid endoperoxides, or lipid hydroperoxides, if we touch another unsaturated fatty acid, okay? And we have also very significant amounts of byproducts, of end products of the free radical, of the peroxide production, as malone dialdehyde, 4-hydroxynonenal, and so on, all kinds of aldehydes and so on. So these are main processes in the body generating these free radicals. And also we don't have to forget the today mentioned production of free radicals during the respiratory chain, in the production, the oxidation of glucose and production of ATP, in the mitochondria. There are also free radical products. Now, if our body does not have enough antioxidant free radical quenching compounds, we get a problem. We get a problem leading to disease and premature aging. To measure these free radicals, we choose, after all kinds of preliminary tests, we know the electron spin resonance test, we know the colorimetric test for free radicals and so on. And we choose, finally, this chemiluminescence test, ladies and gentlemen, because these chemiluminescence tests are very simple, and we have the possibility within 10 minutes with a very, very cheap experiment, $1 per experiment cost us this story, to show you how many free radicals has our patient in his whole blood, what an amount of free radicals we have in plasma, and which is the total antioxidant activity of his blood or of his plasma. Very interesting to start to know where the patient is and to start a controlled antioxidative treatment, and not to give somebody who has no need for antioxidant, just to push him antioxidant every day, okay, with no result, absolutely no result, okay? This chemoluminescence system combines the photon release from a biological sample with the simultaneous production of free radicals in the same sample. For instance, in a small blood sample, as you may see here, we need only 0.5 cc of blood together with a special enhancer for photon reactions, as luminol, lucigenin, or things like this. If we make this combination and we put this in the special cage, we have here a photon multiplier, which is accelerating the photons in the high voltage case, and this is transforming these impulses in electric impulses, which are visualized on this monitor. The more free radicals we have, the higher the counts of these photons, respectively free radicals, on the screen. So we can easily differentiate between a normal healthy control profile in venous blood, where the free radicals production would be around, let's say, 380, 400 counts per 30 seconds. Every 30 seconds count a point showing the amount of counted photons, or a multiple chemical sensitive patient with a much higher amount of free radical in his sample from the blood cells. Of course, the main source for free radicals in the whole blood are the phagocytes. The phagocytes are very strongly inducer of free radicals. Here we have another situation, the serum of a healthy controls and the serum of a cancer patient, with a very significant difference between the two samples also. If we make the statistics, and we publish these results, if we make statistics between controls and atopic dermatitis patients and psoriasis patients or multiple chemical sensitive patients or cancer patients, we can easily see that in whole blood there is a significantly difference between these groups, between controls and these diseased patients. And if we add another stimulants, another oxidative shock on this test, and we just irradiate for a few minutes the blood sample, we see another even more dramatic difference between controls and atopic patients, psoriasis, MCS, and cancer patients. Because when the patients cannot support this stress, they react, illuminate the irradiation of the sample, they react to even more production of free radicals, as you may see here. So we can very well differentiate the levels and see the results of your treatment afterwards. You start a treatment and you check it again 2 days later, 5 days later, or 2 weeks later. Now, to check up very fast the antioxidative activity in your patients, or the antioxidative activity of your compound, which is equally important for the treatment, the antioxidative activity, for instance, of your infusion or of your capsule, you can test it within 5 minutes. How we do this? First of all, we need a very constant and strong free radical producing source. Here we have such an example. It's a very intensively elaborated lucigenin perborate assay, giving us a constant amount of 1.2 million counts every 30 seconds. Extremely strong and extremely constant. That's very important. Because if your source is decaying, you'll never get a good measurement of your free radicals. You need a constant free radical source to see the effects of your antioxidants. Now, what kind of radicals we have in this mixture? If we add a little bit of superoxide dismutase, we get an inhibition showing that we have superoxide radical. If we get a little bit of catalase, we get a stronger inhibition. We have also production of hydrogen peroxide, perborate, of course. And if we get some mannitol, we quench also some hydroxyl radical, mannitol, benzoate, and others are specific quenchers for mannitol. Now, we have the same source for free radicals, and now we are testing our plasma, our serum, or our juice, our fresh juice. We want to see how strong antioxidative effect it has. The free radical quenching activity of this plasma sample, as you may see here, it's quite strong, okay? And this reduces strongly the source up to this amount. Now, this is not a standardized test yet, but I want to show you what's happening in the machine. The stronger the antioxidative activity, the faster the reducing of the counts drop in the free radical source. Here is green tea, even stronger than plasma. Here is ascorbic acid. 10 microliter, 0.1 molar is not enough to block the source, but if I give 30 microliter, I completely block the source. It helps us, this system, to show us how much needs our patients, or since what level and what quantity my treatment is efficient in these people. And we developed for this a so-called 5 minutes antioxidative activity test, where the 100% activity of the source may be inhibited to 50% by 50 microliters of 0.05 molar ascorbic acid. This is our standard unit, one ascorbic acid unit or one inhibitory unit, which is inhibiting the source by 50%. Now, I can express all my results in accord to this unit, to this inhibitory units. Here I have a psoriasis patient. If I get this inhibition with 50 microliters ascorbic acid 0.5, here I'm just giving the 50 microliter serum of psoriasis, and I see how strong is this in comparison with my ascorbate unit. And after this, it was very easy to test all kinds of compounds, ladies and gentlemen, all kinds of compounds. In 5-minute test, 5 minutes takes this and costs it $1. There is no cheaper and no simple test on the market. We don't have on the market, we don't sell anything, but I'm showing you, if you try to get an antioxidative test on the market, you'll see how expensive, how many steps in the procedure you need to conduct it. Here, our 1 unit ascorbic acid, a fresh grape juice is showing immediately 170 units. An apple juice is showing 300 units, ascorbic units, inhibitory units of the source. And if we leave for 4 hours this freshly squeezed apple juice on the table, 4 hours later we will already record a decrease of his antioxidative activity because of oxidation in the air. The same happens if we get a little bit blueberry juice, 311 units. 24 hours later, left on the table, 190, a significant decrease of the antioxidant activity if you leave it in the contact with the air, oxidizing, or if you can your products. It's a huge difference between canned products and freshly squeezed products. Don't forget this well-known water-soluble antioxidants. Ascorbic acid, 1 unit, we saw before. Gamma-glucuronic acid, gamma-lactone, 4 units. Mannitol, 26 units. Glutathione, reduced glutathione, in fact 0.005, so 10 times less concentrated as the others. It has a very strong antioxidative activity. And here 500 units N-acetylcysteine, 540 units L-cysteine, and so on. So you can measure everything, or water-soluble. We're publishing now the fat-soluble compounds, the results with this test. And here the effects of ultraviolet C on the antioxidative activity. There is all kinds of research you can do for your patients with these systems. Now, what are we finding in the biological samples in our patients? What is indicating us the disease process? Look here, we have a control, a healthy people. If we are comparing the reaction in this control, healthy people, in blood, before and after a challenge meal with milk and eggs. And if we take for the same test an atopic patient, an allergic patient, reacting against milk and eggs, look the difference. First of all, the atopic patient, as you saw before, has a much stronger, much higher free radical production as compared with the control. After the challenge, in the control happens almost nothing, but by contrast, in our patient, it gets to a tremendous increase of the free radical production after contact with the allergen. In the gut, after contact with the allergen, a tremendous free radical production, which we see it in the blood. In the blood, we see this reaction. Coffee. Coffee, ladies and gentlemen, is for our plasma or for our serum a significant oxidant. But as long as our erythrocytes has the antioxidant capacity to block it, you are still okay. Not our patients. not patients with chemical sensitivity, not patients with atopic disease, not psoriasis patients. They don't tolerate coffee at all, but nobody tells them that. So here, if you add a little bit of coffee to our plasma, you may see immediately the increase of the superoxide production, because coffee includes methylxanthine, and the methylxanthine is an excellent substrate for the xanthine oxidase. And you get immediately the increase of the superoxide production. If you wanna prove it, and if you wanna help the patient, you need to give him superoxide dismutase, the specific enzyme, quenching the superoxide, and bringing back, as you see here, back to the initial range, the free radical production. So simple is this to check it. Here, lime blossom tea. Lime blossom tea is very nicely reducing the free radical production in a multiple chemical sensitive patient 1 hour after a challenge meal, and is significantly, very positive, very nicely reducing these high levels of free radicals. Teas are very effective, teas, but you have to check what it's doing in your patient. You just need a 0.5 milliliter blood sample, you give a drop of your tea, you see immediately if it helps or not. It's very simple. Here, the same situation, light exposure, strong free radical production in this sample. We did give a little bit of N-acetylcysteine, 15 microliters, 0.01 molar. It's not enough. The source is only for a few minutes inhibited and is coming back to the original level, as you see. But if you add a little bit of grape juice rich in polyphenols, ladies and gentlemen, we have an excellent inhibition of our free radical production in the blood. So helpful could be natural compounds. Here, a similar effect. We have a strong increase of the free radical production in multiple chemical patients after challenge meal. After challenge meal, here is the before challenge meal, here is after challenge meal. And if we add a little bit of grapefruit juice, we get an excellent blockage of this free radical production. Grapefruit juice, cancer patients, you've probably heard about the positive effects. Here we measured the effects of other juices. For instance, this Selagon juice is a mixture of vegetables, quite interestingly, produced in several people with several control people, a highly significant free radical increasing effect in the blood. As long as these patients are okay with their reserves, okay, their antioxidative reserve, you have no negative problems, you just get an increasing of the oxidation. Many of them are reporting that losing fat, you get increased oxidation in the body. But if you get a native blueberry juice, for instance, the same quantity, 500 milliliters, in a patient with atopic eczema, we have a very nice reducing of the free radical production in his blood. Very, very significant reduction by a quite neutral, slightly increase of the radicals in plasma. Here is about the overall effect in blood. The overall effect in blood is strongly reduced by this blueberry juice. You can test everything like this and know what you're doing with your therapy. Hyperthermia, as we saw before by the redox systems, what it's doing in the free radical production. Hyperthermia, systemic hyperthermia, it's increasing the free radical production, and it's good against cancer cells, of course, and is neutralizing the antioxidative reserve in the plasma, for instance, in serum and plasma, to the normal range. Very, very interesting effects of hyperthermia, very interesting. What is doing the photooxidation therapy? The photooxidation is quite interesting. If we just measure the effects in the 50 milliliters blood we just took from the vein, after 5 minutes ultraviolet C exposure, we get a highly significant increase of the free radical in this sample. As you see here, here is the basal level before taking the sample and before irradiating the sample. Now, if we re-inject this activated blood back into the vein, we get a fantastic reducement and drop of the whole amount of free radicals because of the mobilization of the antioxidative defense of the body against this stressing agent. Very interesting, exactly as we noticed in the redosis effects after oxidative stress in the redox potential. Very interesting. So once again, strongly increase of the free radicals in the ultraviolet exposed blood sample, 50 milliliters, back into the vein, in vivo, in the patient, in 5-liter blood afterwards, we get the opposite effect. We get a blocking of the free radical production, which was already increased in these people. Very interesting effect. Vitamin C. What's doing vitamin C? I mentioned before that if your patient are in a strongly oxidative situation, and if your patient have, for instance, large amounts of circulating non-bound, not enough bound heavy metals. It means when the carriers or the protein carriers for heavy metals transfer in ceruloplasmin, thioneins and things like this are not enough synthesized, or the albumin levels are low, you will get such situation. Serum plus enhancer, a little bit of ascorbate, you get an immediate increase of the free radical production in serum in such an atopic eczema patients with metal sensitivity. Think about the catalytic effect of the metal for the autooxidation of vitamin C in serum. Now in vivo, we are giving the 8.5 gram vitamin C as we saw before at the Redox test. The 8.5 gram intravenously infused in these people. Before the intravenous infusion, 16,000 counts, it's an activated, it's an atopic patient. Normal range is at 8,000. Immediately after the ascorbate infusion, 1 hour later, a highly significant increase of the free radicals. 2 hours later, tremendous increase from 16,000 to 278,000 increase of the free radicals. 5 hours later, a decrease. 24 hours later is still 3 times more than 1 day before. In such cases, the infusion of the ascorbate is counterindicated, it's not indicated. And we know that the patient, they have problems. They have a strong itching after this. They have headache. They have herpes reaction and things like this. In blood, in whole blood, we have a similar increase, as you may see here, before ascorbate, after 1 hour, after 2 hours, after 5 hours, after 24 hours. And here by 20 grams ascorbate, we have tremendous amount, 600,000 counts in serum as compared with 18,000 before this therapy. So it's a tremendous firework of free radicals. Everybody heard about chelation therapy. Chelation therapy is quite common in the United States, also in Germany, in our clinic too. We took some attention, we give some attention to this chelation therapy. Well, the redox curves are showing a very nice redoses after the chelation therapy. Here is the basal level after EDTA, and here immediately after EDTA, minus 121, 24 hours later, still a very nice redoses. We would say, well, it's an interesting antioxidative effect. If it's an antioxidative effect, where is it coming, this antioxidative effect? Because EDTA itself is not quenching free radicals, but it's quenching metals. It's quenching toxic metals. And here, the empty columns are showing the levels, the metal levels as lead before EDTA. Here, 2 hours after EDTA, 5 hours, 14 hours after EDTA. You see how much lead is released in urine after this therapy. Nickel, 1.7 to 27. The tremendous amounts of heavy metal, transitional heavy metals may be eliminated, cadmium, chromium, and iron. These transitional non-bound heavy metals are extremely important for the oxidation of the body, oxidation processes, for the autooxidation of vitamin C, for the autooxidation of thiol compounds, okay, and for this tremendous production of free radicals. And now if we see the free radicals, if we check the free radicals reaction after EDTA, we found that the cation combining with EDTA may be crucial for the overall effect of your infusion. It's not the same if you are infusing sodium EDTA, it's not the same if you are infusing magnesium EDTA, and it's not the same if you are infusing sodium calcium EDTA or the magnesium kalium EDTA. Not the same. Also very important is the infusion carrier. It's not the same if you're giving dextrose, it's not the same if you're giving saline, or it's not the same if you're giving mannitol or other ringer lactate or things like this. Very interesting. Look here, one healthy control, the same blood, whole blood. This is the normal increasing scale of the free radicals in the presence of air, of oxygen, as we always did. If we add here a little bit of sodium calcium EDTA, we have a slight, a very, very slight slowing of the increasing rate, but it's not at all stopped. If we add sodium magnesium EDTA, we have a better effect. And if we add kalium EDTA, we have a very significant decrease of the free radical production. The blood cells and especially the macrophages and the polymorphonuclears are reacting differently from patient to patient to your infusion, to your EDTA infusion. So if you choose the right combination, you may see beautiful effects of blocking the free radical production, as here in an atopic eczema patient with metal hypersensitivity. Here are the high radical production, a strong production in an acute phase of atopic eczema before EDTA. Here, 2 hours after EDTA, you may see what a tremendous blockage of the free radical production. A redistribution of iron 3 hours later, next morning, very low levels of free radicals as compared with 1 day before. The patient has an excellent improvement, clinical improvement from 1 day to the other as comparative with when getting cortisone. Such a tremendous positive effect you get from such an infusion, from the right infusion, if you block the transitional free elements, metals, inducing the free radicals in the system. Such patients, as you saw at the beginning, need an integrative concept, and we are very happy to use such tools, such monitoring tools, to know what is the situation before starting the therapy, which is the situation during the therapy, and what is the situation at the end of the therapy. This guy, very toxic with enormous mercury compounds from his mother. He got, during pregnancy, large amounts of mercury and methylmercury, and also a chronic intestinal infection with candida and proteus. After 2.5 weeks, the disease was stopped with an appropriate integrative concept using such measurements. Here, another toxic eczema, bullous toxic eczema, before the therapy, and after 4 weeks therapy, completely disappeared. We don't give any cortisone in the clinic. We don't give any radiation therapy in the clinic. We don't give any cytostatics, retinoids, methotrexate, no. These agents has nothing to do with the causes of these disorders, nothing. They are just symptomatic therapies which are not interesting at all. Here, yes, you may see such a dramatic eczema are coming from all over Germany, Holland, and from Switzerland to us. And after 4.5 weeks, when leaving the clinic, there are tremendous difficult cases coming into our work, and we learned about a lot from these people in the last 15 years. Very difficult eczema, super infected with gram-positive and germs and with candida. When leaving the clinic after 6 weeks, completely restored. Here also a very dramatic atopic eczema, super infected with herpes virus, and also under cortisone treatment from University of Vienna came in this situation in our clinic on cortisone. And he left like this. He was also checked 5 years later from a TV team, wanted to see how it's going with him. Psoriasis, this very dramatic psoriasis is a so-called psoriasis geographica, very resistant against cortisone or ultraviolet therapy. Here, before the therapy, with all these efflorescences generalized, and when leaving the clinic 5 weeks later, the therapy time is between 4 to 5 weeks in the clinic. And here is one of the leaders of the German Psoriasis Association. After his 8th therapy time at the Dead Sea in Israel, came back, and 10 days later, after eating tyramine-rich compounds and drinking beer and drinking red wine and a lot of meat products and so on, get an exacerbation of the disease. And he left us 5 weeks later in an excellent condition. He's symptom-free since 8 years. We notice in this psoriasis and atopic eczema patient that the ATP production, that the energy production, is a crucial point in their disease, and is low, significantly lower in atopic patients and psoriasis patients when compared with controls, with healthy controls. And then, as we know this, we introduce ATP precursors and ATP compounds in the treatment with very good results, and also in some external treatments. And this is one of these products, Energy is called, with ATP precursors. And we noticed, interestingly, that the patient came back and wanted again this product without having any symptoms. And they told us that their wrinkles has greatly improved after these energy compounds. There is no regeneration, ladies and gentlemen, without energy supply for the tissue. If the tissue is not getting its own energy supply for a normal running glycolysis, Krebs cycle, and respiratory chain, you need to supply it in the first time, at the beginning, to improve the tissue condition. As long as you supply, you support the pumps, the membrane pumps, the sodium, the kalium pumps, and you keep running the metabolism and the cell potentials. And here, another case before and after 4 weeks of this cream. Quite interesting observations, in spite that the cream was for psoriasis people. And acne also very effective, increasing the oxidation of the lipids, and with a very interesting anti-inflammatory effect. ATP and cyclo-AMP are blocking histamine release from the cells. And this is the effect of this energy-rich cream. Here was, after 6 weeks, this lady had an odyssey behind her of therapies, all kinds of therapies. Psoriasis, you may see what a disastrous effects we can get in such patients. Tremendous problems in chronic or in acute psoriasis patients. And here, when leaving the hospital, it took 2.5 months until we get this result. Here, another case of very dramatic psoriasis, epidermolysis, erythrodermic psoriasis before the therapy, and 3 months later, there are quite difficult cases we are faced with. And here again, psoriasis children totally resistant to the cortisone and ultraviolet A and B. And here, after 5 weeks, he's symptom-free since 12 years. And here, atopic eczema, superinfected, generalized pruritus, hyperactivity, increased levels of dopamine in the blood, and so on, and in victory position when leaving the clinic. Thank you very much for your attention. Thank you.